So esteemed chair, ladies and gentlemen, thank you for the opportunity. No financial disclosures. So accidental chemical injury to the eye may occur from lime, paint, superglue, cleaning agents, pesticides, industrial solvents, and environmental pollutants. Published literature has infrequently reported such an injury due to inappropriate topical application of a traditional medication. I'm presenting a series of 2 patients who presented after inadvertent ocular administration of a topical lotion containing salicylic acid, benzoic acid, and alcohol named Dadurin, which is marketed as a traditional medication for dermatological conditions. After exposure, both patients had washed the affected eyes immediately with tap water, and both patients were carrying the bottle of the incriminating agent at the time of presentation. This happens to be the particular medication. The box of the medication, which is mentioned, indicated in ringworm and tinea in Hindi. B shows that the composition of the medication, and the labeling on the box is poison. C shows that the particular medication is packaged in an eyedropper bottle, and D is about the same, the labeling on the bottle, which is similar to what is found on the box. So case 1 was the 28-year-old male who presented with redness, mild pain, watering, and swelling following a drop of Dadurin in place of olopatadine. The visual acuity was all right, as was the examination overall, but then a corneal epithelial defect 3 mm into 2 mm was seen, straddling the limits from 5 to 7 o'clock in the left eye. A Ropal Hall grade 1 or a Dua grade 2 ocular surface burn was diagnosed. The next case is of a 56-year-old female who presented with similar complaints after installation of Dadurin 4 days ago in place of brimonidine plus timolol eye drops. The unaided visual acuity was 2/60 in the affected eye, and on examination there was eyelid edema, matted eyelashes, conjunctival and ciliary congestion, and chemosis with confluent corneal epithelial loss in the right eye. Part of the visual acuity was affected due to immature cataract as well. So moxifloxacin, lotepretinol, and carboxymethyl cellulose were prescribed for 2 weeks in both affected eyes, and anti-glaucoma medication was switched to a preservative-free solution. At 2 weeks, the symptoms inside had improved, and the epithelial defects were found to be healing satisfactorily. Subsequently, the eyes have achieved normal epithelial integrity, and there were maintained on lubricant eye drops. Both patients were symptom-free at 2 months of follow-up, and now 6 months of follow-up. So ocular wounds comprise about 7.7 to 18% of all ocular traumas, and they are a major cause of visual morbidity. Previous studies of accidental chemical injury to the eye are limited to household or industrial agents, with occasional reports incrementing formulations of alternative system of medicine, particularly Ayurveda. Only 2 earlier reports of ocular surface injury with salicylic acid-based chemical formulations were found in published literature. So our patients admitted that the similarity in packaging between this medication and routinely used eye drops was a cause of confusion, which is likely why they instilled this agent into the eye. So the drugs that look alike but are intended for different recipients carry such risks when stored together in pharmacies and households. Previous case reports have recommended the packaging of salicylic acid-based medicines to be easily distinguishable from eye drops. However, manufacturers of these medications have not modified the packaging accordingly. Patients with low vision may have added risk of self-induced chemical injury. We all know ocular surface injury from dilute salicylic acid can be mild to severe and may require surgical intervention and may culminate in nebulomacular corneal opacities and vision loss as well. To conclude, drugs that look alike due to similar packaging can result in ocular medication errors, and therefore this case series highlights that the importance of distinct packaging of these medicines which are hazardous to the ocular surface. Thank you so much.
Very nice. Why they have the similar eye bottles? This comes as Dadurin as an ointment or a drop?
A drop, sir. It is a lotion for tinea and ringworm. It is alternative medication. Part of it is a policy issue because there is no regulation on the part of the government how these traditional medications should be packaged. And there is no input from, say, societies like AIOS and, say, optometry associations or maybe pharmaceutical associations or maybe associations of pharmacologists. There is no recommendation to the government. So this is the larger picture, sir.
I just had a question, sir. In fact, I was wondering that when you all knew that, this was a particular agent, a chemical agent which had given this particular clinical condition, why did you all go in for a steroid and an antibiotic also, and especially an antibiotic which also had known epitheliotoxic propensity? And why did you not just go in for a plain simple lots of, let's say, lubricating agents.
That could have been one line of therapy. I agree. Withdrawing the incriminating drug, yes.
Yeah, but topical steroid and antibiotic are usually given for acute chemical burn. Prophylaxis, but steroid mainly to control the inflammation.
Yes.
Maybe that's Dr. Sagarika is a old book teaching that in presence of epidephic, don't give steroids. So the
Actually,
context is different.
actually, I'm not talking about. I'm talking about that you're giving an antibiotic, and an antibiotic which also is known to cause
Absolutely.
epithelial toxicity.
That-
So, if you are giving something which is already your corneal epithelium is damaged, then you're giving something epitheliotoxic, and then you're giving a steroid which is for the, so I realize that yes, inflammation we would prefer to give a, let's say low T, you only given a very low, but to give an epitheliotoxic drug is something that occurred to me.
Yes,
Why?
yes. Okay, ma'am.